Welcome to Diagnostic Imaging's Weekly Scan. I'm Senior Editor Whitney Palmer. Before we get to our featured interview this week with Dr. Shalom Kalnicki about the challenges racial and ethnic minorities face in accessing cancer screening services and the impact of COVID-19, here are the top stories of the week. Radiology answered a long-standing neurology question this week. Is Parkinson's in fact two diseases? The answer is yes. Based on MRI and PET scans, investigators from Denmark determined Parkinson's can either begin in the brain and move to the body, or vice versa. They also hypothesized, correctly, that isolated REM sleep disorder could be directly associated with body-first disease. They published their findings in the journal Brain. In their study, the team examined 37 patients, some with isolated sleep disorder and some without, who underwent both PET and MRI scans that were repeated after 3 and 6 years. Based on these scans, the team determined for patients with body-first disease that examining the composition of intestinal bacteria could be beneficial because Parkinson's patients are known to have a different microbiome. Although brain-first disease is more difficult to detect because it is not picked up until movement disorders appear, the team said they hope these results can add to the body of knowledge that can lead to more personalized treatment. According to brain MRI scans, Hispanic patients are at high risk for developing more aggressive cases of multiple sclerosis. Because of that, say researchers at the University of Texas Health Sciences Center, they face a greater likelihood of clinical disability and job loss. The team published their findings in the Journal of Neuroimaging. There has been little research into how MS affects Hispanics, but this study revealed Hispanic patients have overall lower normalized total brain, cortex, basal ganglia, corpus callosum, and white matter volumes, as well as higher lateral ventricular and T2 lesion volumes at baseline than their white counterparts, potentially indicating differential rates of neurodegeneration or inherent race-dependent brain volume differences. These measures also correlated with the higher baseline expanded disability status scale scores Hispanics had. Everything taken together, they said, points to a race-dependent mechanism that leads to the accumulation of irreversible clinical impairment in MS among this patient group. Common misconceptions about radiation dose could be making it harder for emergency radiologists to capture the best CT images with some patients. That's according to radiology, physics, and biomedical engineering professor Tim Stikatovich at the University of Wisconsin. He spoke at the American Society of Emergency Radiology annual meeting this week, highlighting how dose worries could be impacting pregnant patients, as well as those who have had several scans in the past. According to Stikatovich, radiologists do not need to worry about dose levels when imaging a pregnant woman suspected of pulmonary embolism. The CT levels are already so low, they do not impact the fetus, and going lower renders exams insufficient for diagnosing a condition that could kill the mother. In addition, he said, radiologists can proceed without worry with head CT in this group because there is very little leakage outside the beam used to image the head. It would take up to 200 scans to impact the unborn child, he said. And lastly, be careful how much weight you place on cumulative effective dose. Currently, there is no literature that links cumulative effective dose to cancer increases, nor is there a consensus about how far back to sum the exposure. Besides, he said, if you forego an exam and leave a patient with undiagnosed chest pain because you might increase their cancer risk by 0.001%, that patient could be dead within 24 hours from something that you could have helped avoid. And finally this week, Diagnostic Imaging spoke with Dr. Shalom Kalnicki, Chair of Radiation Oncology at Montefiore and Albert Einstein College of Medicine, about the challenges racial and ethnic minorities face in accessing cancer screening services, as well as the impact COVID-19 has had on this existing problem. Dr. Kalnicki also shared with us steps institutions can take to improve the situation. Here's what he had to say. All right, well, Dr. Kalnicki, I really appreciate you taking the time to jump right in and I guess to provide some context around this topic. When it comes to screenings for patients, what challenges, prior to the pandemic, did racial and ethnic minorities already face in accessing these services? And then what difficulties did COVID put on top of that?
The answer is a resounding yes. And the difficulties that people talk about a lot in cancer care, but not enough as they relate to cancer screening, relate to the minorities and disparities populations issues with the financial toxicity in cancer care. This is a well-known phenomenon. So imagine a woman, young woman, who has a mammogram, right? Simple for screening mammography, breast cancer, needs surgery, chemotherapy, radiation. That woman who comes from a perspective of total health will have in 1 year, in the year following, approximately a minimum of 140 specialty encounters. Now you take a regular health plan that everybody takes from their employer that says the copay is $15 for a primary care physician, $35 for a specialist. Boom, 35 times 140 minimum in 1 year. So for economically stressed populations, financial toxicity of cancer, and this is just the cash, not to speak about stretches with job losses, not to speak about family care, not to speak about everything that comes around it. For them, it is so immense and it goes around those communities that they don't want to know. They don't want to know they have cancer as a stress and financial toxicity prevention maneuver, because almost everyone with the incidence of cancer knows someone whose life was tremendously affected from the socio-economic standpoint by being successfully treated for cancer. And we underappreciate that tremendously. We are blessed to be in a country with 22 million plus circulating cancer survivors. We fail to take proper care of them when they belong to the minorities and socioeconomic distressed population, give them the benefits they need, the social and economic support they need. So when this backtracks toward cancer screening, the question is, if I have cancer, no matter, you can cure me, but it may ruin my life.
Right.
It may, and I don't want to get into this. And this is huge and tremendously underappreciated. We talk about health literacy. We talk about socioeconomic factors in terms of knowing all about when should I have mammograms, the different, when should one have, PSAs and CT screening for lung cancer. This is all great, but we do not correlate it. And we on the treatment side feel this every day. We don't correlate by saying to the minorities and socioeconomically distressed populations, don't worry, if you have cancer, the system will take you by the hand and you will end up in a good place. We will make the maximum effort that the day you have the screening mammogram and the day you finish your treatment, you will be as close as possible to your normal life. It will happen to a middle class, socioeconomically stable person in much higher proportions than it will happen to a socioeconomic distressed or minority population. And we see them running away from screening because they don't want to know. So this is the socioeconomic factor of the well-known financial toxicity of cancer care, as we call it in publications, is something that makes them run away from it all. And this is the number one in our head. The second piece is the idea that in cancer screening, many populations who have low health literacy levels and listen to advertisement of drug companies, healthcare hospitals, institutions, and if your health and healthcare institutions, hospitals, and so on, if you put together the whole bulk of advertising of insurance plans, providers, pharmaceutical and device companies, and so on, they believe that we screen because we need to feed that monster, which is the healthcare system grind, and they don't trust us. And people with low literacy level, the first question they ask us is, can you guarantee that I really have cancer? And you feel like, how does somebody who knows very little in terms of health literacy, how do you explain what cancer is, what the dangers are, and the importance of treatment compliance? So it is not just, in our view, throwing people into screening. Screening has to be a consequence of true population health. And the same way we have now a growing population of vaccine deniers because of issues we have in health literacy and our failure to explain to everyone what it means, I feel we have a growing population of screening denials. So these two factors make the proper reach to the distressed populations a very specific scientific research, a population health research and approach issue that we dedicate ourselves tremendously in trying to understand better what the barriers are and why we are dealing with this in such a manner.
So then with that as a backdrop, is there anything that the pandemic has added on top of that has made it even more difficult perhaps to bring these patients in for screening?
It has put in fear of leaving your pod or cocoon. It has added that at a logarithmic level. And we have also incredible logistics problems because for the patient, or you shouldn't call patient, because if you are doing a lung CT for lung cancer screening, a low dose CT, you are talking about a healthy person who just happens to be smoking maybe. So it's really for the population screened. Logistics have become much harder. Social distancing. You were 15 minutes late for a screening appointment. You'll have to wait 1 hour, but we'll squeeze you in. You are 15 minutes late for a screening appointment because of New York traffic or because of childcare or because your job asked you to stay a little longer. If you are socioeconomic or otherwise distressed by all those things like minorities and socioeconomic distressed populations are, we have to reschedule it. Right. And you cannot just hung out in waiting rooms like before and things like that. So even a simple, quick screening low dose CT, we have to screen for the COVID symptoms. We have to do this, do that, and with all the COVID safety, the give and take between the facility and the person being screened has to be much more precise and much more organized, and with the multiple failure points in an urban setting where the minority and the stressed populations usually live, it's very, very difficult.
Right. So then what can be done potentially, in this environment that we have now that's just kind of lingering on and potentially going to get worse as the colder weather comes around? What can be done to encourage these patients to come back in? And then what strategies or techniques can potentially be used to make that a reality?
The number one thing that people have to separate is to help people with health literacy levels who are really basic, understand the difference between a social gathering and an organized flow in a healthcare facility that is maintained COVID safe by the strictest standards. It's a hard thing for individuals who don't have an innate sense of sterility and health safety matters brought in. So the first thing one has to do is to understand how people's head works and why people are scared. In April and May, you circulated through New York City, the neon sign said, wash your hands. It was a great thing. Wash your hands with soap, actually, they said. And it was a great thing. We forget that we have to reinforce basic things in people. And what the difference between being clean, dirty, safe, unsafe, et cetera, has to be much clearer in people's heads. It's not just the issues about the mask. That's the most visible thing. This is huge too, but obviously. But we need to make people understand that when they come to us, they are safe. After that, we need to make people understand that in a time that they don't know what the future of their health insurance plan, what the future, and this is the difficult part, what the future of their job, health insurance, et cetera, will be, uh, we we are going to take them by the hand, and we are not going to dump them if they end up having cancer. That's their basic fear, because we are now having, we are, the problem that we see when we talk to minorities and distressed populations who get positive diagnosis, who get the diagnosis of cancer, is very simple. You have decades where your health insurance was based on a job. You have the highest unemployment rates, at least since the Great Depression in the 20s, in the 1920s, and everybody is uncertain. So putting the COVID fear and the uncertainty regarding that is very expensive cancer care going to be paid or not, I stay away. I stay home and pray that I have nothing. That's their, and it's such a logical reaction. And if we need to, as a society, we need to take a deep breath and make, health care to a certain extent a right of the disadvantaged populations, to get them into screening big time. If it is very important that we solve that problem.
So are there any strategies or initiatives that your institution has implemented to not necessarily target, but concentrate on these groups to give them that comfort level that they need to come back in for screening?
Yes, we tell them that we are going to take them by the hand. We are going to help them be either if they get a positive screen, we won't dump them. We are going to help them get emergency Medicaid. We are going to get them to sit, a social worker or a financial advisor is going to sit with them and get into an exchange and get them in somehow, that we are going to create something that will not abandon them. And that's the only way we found to get them really to start coming back, that we are safe, we are clean, we actually are paying much more attention in transportation and family issues for appointments, because it disturbs our logistics so much. And you can imagine in a busy radiology practice where you are lining up patients for mammography, lung CTs, and all the other screening and imaging procedures that all this takes. So we pay a lot more attention in helping patients organize lives around their appointments. So we have something called Care 360 that we use for patients for our high-risk clinics where screening is very important. And we use them also for our cancer survivorship screenings, where social workers continuously via telehealth access barriers to care. And logistics is big. So we have transportation systems, we have, answering of safety questions, we have issues with all these logistic issues that prevent those patients from coming. We try to knock them off one by one.
Right. Well, then pivoting and looking at the role of the radiologist in particular, is there
Mm-hmm.
anything that the provider can do, either on the front end or during the appointment itself, that can, really kind of augment this feeling of comfort that the patient has, and help them understand that this is, a service that they need to be sure they stay on top of?
The radiologists partner with us in a big way in two key aspects. Number one is quick input. If somebody has a mammogram or a low dose lung CT for cancer screening, they don't sleep until they hear. So the radiologists partner with us in considering cancer screening a psychiatric urgent matter. That's the approach we take. It's not just an image on their workstation. There is somebody trembling at home, waiting to get our call and saying you are fine, or saying you are not fine. It's BI-RADS 4, let's say, and you have an appointment with the breast team tomorrow morning. So that's how it's key that the radiologists partner with us. And the other key partnership in these times of high tension is the time between suspicious and intervention. So that stereotactic breast biopsy, that transthoracic biopsy of the lung nodule, that the interventional procedure that follows that, especially for patients who are minorities and distressed and have all these COVID logistic problems, and the idea of having cancer is like the drop that spills the water in terms of stress levels. Especially with that, the timeline of care is key. It cannot be like, call our access center and we'll see when we can do this. So it has to be a really orchestrated timeline of care. not to make people flip out completely. So the partnership with the radiologist to achieve that is huge. And that's how they actively promote screening by creating this kind of level of service that deflates the tension balloon rather than make it explode.
All right.
The participation of the radiologist is key in that.
All right. Well, it sounds like there have been a lot of positive steps put in place, but again, it's a very, difficult environment right now. So are there still challenges or stumbling blocks that you have picked up on in bringing patients back in for screening despite your best efforts?
Despite the best efforts, we are not at 2019 levels. We are still trailing. And especially the populations we are talking about are still trailing by a factor, depending on the subspecialty that you look in the 14 disease-based cancer universe, where we have screening and prevention, diagnostic and therapeutic and survivorship tracks. So we look at this by the 14, cancer groups: head and neck, breast, colorectal, blah, blah, blah. So then we look at it like this, depending, it swings between 20 and 5%. So there are places we are doing better than others, but we are still trailing. And to accomplish this, the challenges are: number one, new vehicles of public education via telehealth. The idea of doing what we were doing in the past, going to churches, schools, community centers, parent-teacher association meetings, and talking about mammography, colonoscopy, CT colonography, PSA, that's dead. We need to figure out, what to do. And this is, how to reach out to these populations. So we are embarking now for things like cancer screening, HPV vaccination, and so on. We are embarking now on a YouTube channel type of approach and making short YouTube videos in Spanish and English first, to make sure that we reach out to the populations. And we are going to try to send the community centers, the parent teachers associations, the church-based, the faith-based organizations, everybody, our public health department is going to keep sending people links. And we are going to see how that works. So we are actively looking for telehealth sort of, we think of telehealth about like telehealth visits and so on, and radiology images on remote screens, but we are thinking of telehealth approaches to cancer screening and prevention.
Right, excellent.
And embarking, this is the program for the last 3 months of this year that we are heavily moving into, and we'll see how it works and how it affects the.
Well, that was my next question. Have you seen an impact of this yet, or is it still kind of ramping up?
We have just started. The people who started coming because of it love it, and and we are finding something very interesting. We have relied for years in reading materials, written pamphlets in waiting rooms, local newspapers, putting, pieces of colorful papers in community and faith-based organizations and so on. People like the screen. People like the screen. And grandma may not be so active on the screen, but the child who is in the 40s, who sees the YouTube video will tell grandma to come for her mammogram, and will drive her and wait in the car, and we will go to the street, take her in safely, we deliver her back to the car, and it works. It's anecdotal. We will have numbers next year because we are tracking this very, very carefully. And I hope that in a year from now, I can give you beautiful numbers, but I don't know yet.
Well, fingers crossed, because it sounds like a great initiative and a great way to reach people that you can't access through traditional or previous methods.
Correct.
Well, I
I
appreciate
hope.
this. Is there anything else about the need to access these patients and bring them back in that we have not touched on that you think would be important to include to kind of give people a very comprehensive view of the importance of this and what you're doing?
Was the lack of awareness by even the healthcare population, the providers population, is such that spreading out the word that the minorities and socioeconomically distressed populations need help desperately in the cancer screening to treatment continuum and how it affects their lives is fantastic, because we all have hopes that we are still a community-minded society at large, that we build a society based in certain immutable parameters, that we are here for each other in a way. And I believe that awareness is the beginning. We manage the cancer service line by sharing data and saying almost nothing. You put the data in and you hope that people will react positively, and they do. So what you are doing by putting it out there, we need to think about those populations. We need to think about these patients. We need to create a network that helps them get to the desired health outcome. Is I think, extremely important work.
Thank you so much for taking the time.
Thank you. Nice to meet you.